I think the topic of this session is the future is here now. And what I'm going to do to follow David's talk is share a discussion we're having with health systems. I'm a family doctor with some training in public health, but the way the health systems are forging ahead with this idea, the same points, often with you. As I look around the room, there are a number of you engaged in these efforts, but all too often without you. So my main reason for coming is to say I think the health systems need your help, and I hope we'll have the sense to ask for it. But you actually may need to edge your way into this discussion and point out how you add value to work that's really moving quickly. So what I'm going to talk about is a movement that's national about an integration between primary care and healthcare more broadly in public health, and how fast that's moving and what it means to you and to me and to the people who live in our communities. Let's see. This really comes out of an Institute of Medicine report. Most recently, it's a 2012 report. Of course, this issue about the relationship between medical care and public health is long and deep. But the issue about whether it's time to bring those two groups back together again has really taken on some sudden currency. Came up with CDC and HRSA wondering whether those two national or federal organizations should better link their resources. They charged the IOM to put together a committee to look at integration and whether it's time to do that, and if so, what it might look like. I was on that group. We spent 1.5 years looking at examples of integration of primary care and public health around the country, found a bunch of them, and made a couple conclusions. One of them is that integration is not simple. That seems pretty obvious, especially if any of you have ever tried it. It's also clear that we're not talking about merger, so I'll come back to that point. But in the IOM report, we talked about integration was the linkage of programs and activities to promote overall efficiency and effectiveness and achieve gains in population health. In other words, what can primary care, the clinical world, and public health do together more effectively than we can separately? And we found there was a spectrum of that. It's not merger, so all of you who are quickly flashed the idea of this means the healthcare system's going to take all the money out of epidemiology and public health, that's not what I'm talking about. And for my primary care colleagues who are thinking that means we're going to take money out of public health who doesn't have any anyway, that's not it either. This is really about how do we step back and look at healthcare more broadly, as David just talked about, and ask the question of what could we do better and how do we do that. The reason for doing this right now is pretty straightforward. It's all the reasons you know well about healthcare costs, the trends, but there are other reasons too. All that healthcare data, with electronic health records start coming out, increase in health research that's actually looking at that data. I'm going to talk about some very fast-moving parts on that. The Affordable Care Act and the new funding opportunities. I'd point out the CDC's technical assistance on the community benefit as an example of that. There's a window. And that window is open now, and I'll show you in a few minutes. Folks are moving fairly quickly. I don't know how long that window is going to stay open. It's not forever. And I think this is a time for this group to engage, not just in theory and abstractly, but concretely and immediately in the work underway. By the way, when we looked at the examples of integration around the country, we did find quite a few, actually. We actually found a large number, relatively few of which were sustained. And when we looked at the examples of where there were programs between primary care and public health, including EPI, that were sustained and effective, should co-outcomes, we found that there were 5 common goals, or 5 common principles. One is they had common goals of improving the health of their local community and population. Pretty straightforward. 2 is they actually engaged with the communities. To look at David's slides, and as you guys know, communities are complex, and one community doesn't map to another. So you actually have to know the group that you're working with, and King County is not Nashville. Aligned leadership turns out to be really important. There's a degree of trust that occurs over time of working together, and that can be hard when everybody's feeling poor and feeling like anything you do together risks losing what you have. But the successful examples were able to overcome that and figure out they had more they could do together and reasons to come together than they risked losing. They did worry about sustainability, and I'm going to talk about money a lot in a few minutes. And to this group's point, in every case, there was use of common data that was analyzed together for collective decision making, and that shared data is absolutely key and where we need your help in particular. Now, sharing data and mapping it, looking at outcomes, of course, is nothing new. This is the county health rankings mapping for for North Carolina, just showing how we have similar variation by county. By the way, I would add, because I helped start the North Carolina Medicaid program, still involved with it, we have a similar ranking like King County, except we can go down to neighborhood because we have primary medical data and look at health outcomes and try and figure out what to do about it. I'll show some of that in a minute. But that's pretty much standard. What's new, and now I'm going to use the Virginia example that David talked about briefly, is the ability to have health exchanges that pull data in from multiple sources, including the healthcare systems, but also public health and the larger community, aggregate them, de-identify or other ways of protecting confidentiality and looking at patterns. It does some really startling things. So here's an example. Have any of you seen this before? By the way, a lot of health systems have. This is what happens when you take multiple health system data. This one is around stroke rates, hospitalization rates for the entire state, actually over 4 years, and they looked at geographic distribution. In this case, they smeared it across counties, and what they found was there was a huge variation depending on where people live. That's not particularly surprising. On the other hand, if you're a health system in Charlottesville or Norfolk, or if you're down where I'm at, just below that border in Durham, then that stroke rate starts to look really interesting. One, of course, all the productive lives lost, years of life lost, but that's a lot of money on health care costs that are potentially savable. So this map starts to look, one, as having public health benefit. It also starts looking really interesting about what's going on in those red areas that we could do something about to actually reduce some of that preventable illness. Now, this one's perhaps my favorite. This one is not been done by a public health agency. This is done by CalPERS, this California State Employee Health Plan, looking at avoidable healthcare costs among their retirees and mapping them to county. And they found huge variation with most of the excess costs being in the Central Valley. By the way, they also found some really interesting patterns where if you look at SES, there's some places that ought to have worse health outcomes than they do, meaning there actually is positive deviance. There's some places that do well that we could try to study and understand. But the amounts were major. So this is the amount of excess expenditures per person that CalPERS thought it was spending. Now, they use some very conservative definitions of avoidable expenses, but for diabetes alone, almost $3,000 per person per year avoidable cost. We're talking about we need some money for epidemiologic analyses. These are starting to add up when you have large numbers. If they're diabetes and hypertension, it's almost $4,000 per person per year in avoidable costs. Now, if you add in complications like heart, cerebral, vascular, renal disease, it's $21,000 per person per year. Folks, there are a lot of folks who are California retirees, and that's a lot of money. So the reason this is starting to really move quickly is folks are realizing that's avoidable costs that could be reallocated, moved around to try and figure out how to keep people healthy and also save some money. Now you may wonder, okay, that sounds really nice. Has anyone ever done that? Or could you actually do it? Hold that thought. The answer is yes. But what CalPERS is doing is actually putting together a Center for Innovation to look at ways in which you might intervene within those counties, partially tracking outcomes, but also figuring out interventions they could do like medical home models, value-based purchasing that actually allow them to spend their healthcare dollars more appropriately. And at least the last time I talked to folks with this, they're working with Kaiser in the health department. So there may be folks in California who can catch me up on that. I'm about a year behind. But point is, the dollars are starting to be so major and the health outcomes so abysmal that folks are starting to look at bridging, looking at the data, and then designing interventions that might do better. It's not just California, though, or the West Coast. There are days in which some of these ideas make it to the Southeast. So this is Charlotte, North Carolina. My colleagues in Carolina's healthcare systems, they're worried about an increase in emergency room rates, especially in Medicaid, because we're on a mixed model with Medicaid. So they actually took their primary data, worked with their health department, at that point they were merged, and actually looked at emergency department utilization for primary care services in Charlotte and found just like all those other maps. In fact, every time we do this, we find huge variation. There are neighborhoods, communities in which people go to the ER for primary care. even though there may be a local primary care office that's nearby. They actually could drive past it to go directly into the ER, and the question is why, and they're exploring that. Here's a map from Durham, where I'll give you an example of what we did about it. This is everybody we have data on, so it's a bit over 90% of the county of 270,000 people. With hypertension, we've actually done cloud mapping. We did this with our health department and my own health system with part of a CTSA, an NIH research grant. So these are actual people, and we're looking at concentrations of people with hypertension. And then what we've done is we've started to add in neighborhood resources. So we're looking not just at what's missing, but what's there that we could build on. Because this is really around figuring out not just that something's happening, but what could you do about it in a reasonable period of time with the community that they would feel comfortable about and if not proud of. This is another one. This is diabetes. It's almost the same map. In this case, I'm just showing you a difference because in this case, every one of those dots is a person. Now, you wonder about confidentiality. We had a jitter. So it is a person, actually a household. We mapped it to the primary household, and then we added some jitter to protect confidentiality. The couple things that became interesting, one is we had 14,000 folks with diabetes in the county. That means if you're over 40, 14% of the folks in the county have diabetes. These are starting to be big numbers, and that matches up reasonably closely with our Durham County and North Carolina statistics. It is not at all it is not ethnically or racially evenly spread. And just like it's not just geography that matters, but race, ethnicity, and SES matter. Put all those together and raises the question of could you actually zoom in on some of those communities that have all that risk, all those higher rates, and actually make an intervention. So this is the zoom in. This one now actually has degree of hemoglobin A1C control. I don't expect you to read all the information, but what you see is successive stepping in because we had the primary data. And now we're looking at where the churches are, where you can buy alcohol, where the grocery stores are, where there is alcohol and no grocery stores, and that's a significant issue, where there are churches that might be sources of interventions. In fact, we have now a number of programs with those churches trying to help them become health hubs. Barbershops are an important role too. This is something where we're now starting to look at interventions that could be done collectively based on those data. Now, this is what an intervention looks like. As we zoomed in, one of the areas that we found turns out to be some elderly high-rises. Everybody in those elderly high-rises had a primary care doc, every bloody one of them. In this case, our initial run was 350 patients. They averaged age 70. They had average of 10 major health problems simultaneously. It goes with the age. 44% had a major psychiatric disorder. All were homebound, 84% African-American. Very few of them had ever graduated high school. Some of them had never graduated elementary school, and their average income was $7,000. They had to pay 25% rent, so they were living on $5,250 per year. They did not eat on weekends because Meals on Wheels doesn't deliver on Saturday and Sunday. So these are, if you know the medical term, the tea and toast ladies. So they were basically hoarding food to carry them through on the weekend. Now you may think, okay, this is social determinants. I mean, what can you do? Hopefully, they have housing. Maybe we could do something around food, which we did. I'll tell you in a minute. But our first thought is, the other thing they're suffering from, even though they have primary care folks, they actually rarely get seen by them. These are the folks with the walkers. They have disabilities. They have to arrange transportation to get to the office. The primary care folks almost never see them. And for any of you who have medical backgrounds, these are folks who come in on Friday afternoon with a bag of medicines, and you aren't quite sure how many of them they're actually taking. And they're usually from more than one or two or three doctors, too. So, I mean, what do you do? So what we did was actually be smart enough to listen to our partners, which included the Housing Authority, the Council on Seniors, our Mental Health Agency, Health Department, of course, Social Services, our nursing school, which had some very good ideas, our Center for Aging, Psychiatry, and decided that rather than a traditional model of people come to us for healthcare, we would go to them. And we'd actually put a team of PAs and NPs backed up by one of my faculty family docs. In fact, that's Robin. On the picture, and we'd bring care door to door to them. Now, it was entirely voluntary. You had to consent as a patient. Every single patient consented, save one who was hallucinating. And all the docs had to consent, and every one of them consented, which surprised me because we were offering teams of providers they had never met would visit a patient they rarely saw, see that patient on their behalf, and send them the records and keep in touch. I mean, what crazy doctor would agree with that? On the other hand, every single one did, Duke, non-Duke. And the reason was we weren't doing any good by them anyway. So hopefully we could do better. So we did the team. It was a bit of a gamble. We did have the health system put the money in as an experiment. And in 1 year, inpatient utilization dropped 68%. Okay, folks, what else drops inpatient utilization 68%? Do you know? The only thing I know of is polio vaccine, not flu vaccine. My point here is that part of the problem, and you know this, is the way we deliver care is doctor-centered and office-centered. And we're in an era in which most disease is chronic and the medical interventions are ineffective. And while we know that, we don't have a way of delivering care differently. But because of the changing finances of healthcare, there is now a mad scramble to figure out how to do it better. And we need you in that discussion. By the way, it didn't save any money because people actually started taking their medicines. Home health care costs went up. But until actually this year, our health outcome for this low-income minority psychiatrically impaired group had better health outcomes than the Duke faculty. 79% of them had the hypertension control, and if they're diabetic, it was 84%. So part of it is not just figuring out the data, but helping us figure out the interventions and tracking those health outcomes. So what we're doing now in Durham, and we're starting to see around the country, is partnerships between health systems that have large concentration of their patients, public health departments, and community groups trying to figure out how do we actually shift this from a discussion about healthcare to a discussion about health. And what would it look like to have healthy people and healthy communities? It's being driven because of the financial issues, but it's making us ask questions, how do we help support healthy schools and neighborhoods? So Duke actually now partners with the school system to run the school clinics. In fact, we did some of those startups. We're looking at ways in which there can be safe places to exercise. David didn't show you a map of where the sidewalks aren't in Durham, but I can show you, for King County, but I can show you where they're not in Durham, and it's where the obesity rates are high. So how do we actually work with the county and with planning to help make it safe to exercise? The places that had the highest rates of diabetes had no grocery stores. They had fresh fruits and vegetables. They do now because the data was so compelling to the zoning board that actually the county put up a zoning ordinance and actually put up some money to bring in abatement money to bring in a big chain grocery store, provided they had appropriately priced fresh fruits and vegetables. And how do we have information on health available to folks? Boy, this sounds good, and my health system does it because, by the way, this is a lot of where our own employees come from, or those same neighborhoods. So this is doing good and doing well. It also scales. So we did another program in our Medicaid network. I help oversee a 6-county network, looking at whether we could reduce asthma rates. We actually hit a 70% one-year reduction in asthma ER visits and admissions by actually just getting the schools and the parents and the primary care docs to agree together. But that's not my point of this slide. My point is that model scaled up across the state. And over a period of 4 years, we actually were able to reduce asthma admissions statewide for kids with Medicaid by 65%. We're no longer talking about whether we can make a 3 or 4 or 5% difference in health outcomes. We're actually targeting in on groups for whom we're poorly serving and asking, can we make a 20, 50, 60, 70% difference? It is possible, and it's being done all over the country now. By the way, it does save money. This is an audited financial report requested by our legislature looking at our North Carolina Medicaid model that runs on this model. It actually was also cross-checked with the Office of the Controller. What it shows in the blue line is our actual cost for our PMPM. We're not on a capitated model, but it looks like it, versus other states, And what you see is it took us a couple of years to figure out how to do this. It's very easy to spend more money doing good things that don't work. But data matters, and as you drill down and you understand and you listen, you actually start to bend the curve. And in fact, at this point, we saved the state several $1 billion in healthcare, and we're actually looking at how to move this to a statewide, a much stronger model, perhaps with Medicare as well. So it does work. Now, I've given you a bunch of examples from scattered states in Durham. It turns out these are all over the place. And in fact, they're growing rapidly. In fact, we probably find a new one about every few days, certainly every week. So the Practical Playbook is a program sponsored by the Beaumont Foundation, CDC, and Duke. We're the coordinating center to try and gather up these examples, analyze them, and share them with you. We started about 1.5 years ago on the work. We launched about 3.5 months ago. It's a collection of the stories and resources. If you Google Practical Playbook, it'll come right up. It gets quite a bit of use, as you'll see. The goal is to actually provide these sort of tools, information, resources to public health professionals, primary care teams, and other groups, hospitals, healthcare investors, academic institutions, community groups, about what works. It's not like you can take a model in one place and just put in another. What are the core principles? What are the elements? How do you do this sort of analytic work? This is intensely analytic, which is why we need your help. The steering committee is me from Duke Community and Family Medicine, Brian Kashrushi and Jim Sprague for the Beaumont Foundation, and Denise Koo from the CDC, and we're working together to sort out all these stories and get them out to you. We do have a national advisory committee. I'd call it ASTO in here because they've been such a great partner, but American College of Preventive Medicine, CSTE, you'll see right on that top line. A number of academic groups, CMS is in here, American Heart Association, New York City Health, and Kaiser. They've been helping us look for these and make sure that the advice we're giving is appropriate and helping disseminate it. This is what it looks like if you go online. It actually talks you through on your left-hand side about learning about what integration is, what those core principles are that I talked about, the value of working together, some of the language issues. It's not just a rift or chasm between us based on history or funding. We actually use language differently. And sometimes we think we're talking to each other, and it can take a long time before you realize you actually didn't ever agree in the first place, because public health primary care partnership means different things to different people, and unless you actually spend a little bit of time talking about what you mean, you can get yourself in trouble. So we actually have some of those commonly misunderstood terms on there too. And then the mechanics of doing this. How do you actually come together, make it work, learn? It often won't work the first time. How do you learn from that and keep going so they actually have sustainable projects? And then how do you share, because there's so many of these. Let me give you some examples of things that are loaded. We have, I think, 35 success stories loaded already. We have at least that many still to load because they're adding in fast. And we have about over 1,000 resources mapped in, enough that it's overloading our search engine. The Maryland Million Hearts, many of you know, this is part of, of course, a multi-state model. My point here is it's a lovely collaboration between Department of Health and Mental Health, local communities, health systems, nonprofits, and they've seen a 27% increase in blood pressure control so far. I think they're going to do better still. Massachusetts would be another, and we've got folks from there. The Community Asthma Initiative, Boston Children's Hospital in the middle of that. Now remember, I was proud if we hit 70% reduction and then statewide 65, where they're reporting out an 80% reduction in pediatric admissions. Once again, as you target, you use the data to identify the communities, you design your interventions, you can hit some staggering improvements. So with all those stories are out there. We have had 14,000 visitors to the site. I hope you'll use it. It is completely free. About a third of folks come back repeatedly, 60,000 visits, and that's in the first 3.5 months. I would forewarn you that at this point we have so much loaded in there, the search engine is bogging down. So we're actually in process of having to overhaul the whole site to make it easier for you to find exactly what you want, but it's up there, you can use it. So the key elements in all this, I'm heading towards done, is that data matters. You guys know that, but what you may not know is the fact that the health systems are starting to aggregate the data and analyze them, look for patterns and design interventions. There aren't that many good epidemiologists around, so I hope we can help you edge into that space if you're not there already. The other is hotspotting is really a potent tool. A third is that coordinated community interventions, as David talked about, really matter. In fact, it's the only thing that works. And that there's an IT infrastructure that bridges between primary care, healthcare more broadly, and public health that seems to be key to this. Now, before I quit, I'm going to tell you about a couple other things that are moving really fast. The stuff I've given you is over the last year. Now we're going to talk about the things that are even more recent. How many of you know about PCORNET? Anybody? Oh dear, that's what I was afraid of. Okay, so PCORNET is a national network to collect data out of electronic health records from healthcare systems, from primary care up to big academic health centers. It spans 20% of the US population. It was just funded. It's NIH and PCORNET, Patient-Centered Outcome Research Institute, to gather and aggregate data and look for patterns of utilization as a research tool to try and understand those disparities and the reasons and what can be done about it. It's a community of research, has 11 clinical data research networks, 18 patient-powered research networks, all wrapped into a big infrastructure based at Harvard. The data analysis site is at Duke. That's its distribution. It is all over the map. Everywhere from big urban to rural. Geisinger's in the middle of it. Doesn't have any of the big federal networks, but does have except the HRSA-funded health care centers are often in it. So it's aggregating data out of all those sites into a collective entity. It has a national coordinating center. I don't expect you to read all that, but I'll leave it with you. The HHS agencies involved in this are NIH, FDA, AHRQ, CDC, CMS, ONC, and ASPE. So a big national project to gather data, aggregate it, de-identify it, look at patterns of utilization, make a difference. So this is rolling. This is funded. It is out there. Starting to collect the data and look at those intervention patterns and look at trials that can be done. Other related activities happening right now. National Quality Forum has a report that's actually up in draft form on improving population health that will, if you haven't seen, will be of interest to you because it talks about the same themes. Now, if you don't know NQF, this is the group that advises CMS on metrics and payment, especially metrics. So if we're going to do population health, what is it we need to measure and how do we want to do that? CDC has the Community Health Improvement Technical Package, which is of intense interest to every health system, nonprofit health system in the US, and should be at least of interest to you because it's going to be the advice about what nonprofit hospitals need to do to keep their nonprofit status by partnering with the community, finding identifiable opportunities and designing and reporting on those interventions. MedPAC, something I suspect this group often reads. This is the Advisory Committee to Congress on Medicare. The June 24 report, so this is hot off the press, is measuring population health outcomes, and a report to Congress on that. And then the IOM, of course, has the Roundtable on Population Health Improvement, Building Capacity for Population Intervention Research, Population Health and State Innovation Models, and Paying for Population Health, with new reports scheduled to come out this summer. My point is that this space is moving almost by the week, some days by the day. If you are not yourself or your organization connected in with it, I don't know how long the window's going to be open, because there is so much energy looking at how do we do these interventions, how do we design them, that it's one of those once-in-a-lifetime opportunities. And I would really encourage you to connect. Now, again, as I mentioned, hopefully some of our more enlightened health system would it ask for your help. Others will go ahead without you. And I'm sorry that is true, but part of the agenda of the Playbook is to say, how do you get in that space if folks don't even know you exist? Because we need your help. Just to close, the way this is playing out is academic health centers have also discovered EPI. And to give my own department of community and family medicine, we've been in the space for a while, but actually in my own department, I have 100 faculty on campus, about 200 counting the community sites. I've got 16 epidemiologists, 8 of them with PhDs. So academic health centers are starting to look at, hey, this is something we better learn about and actually help learn more about. So I think there's an opportunity for collaboration, competition if we don't do it well. But I came here to actually ask for your help about how we partner together because it is time and our communities need us. Thank you.